Hello and welcome to this holiday edition of the CTSNet Beat Pulse. Crisis hits CTSNet as the whole office abandons me, so I have to do this podcast on my own. But don't worry, I've still got my friends, I've got you. So we're going to go through all the usual articles. We've got some interesting things on atrial function mitral regurgitation. Let me tell you all about that. Risk for transfusion and an amazing surprise about intercostal catheters in thoracic surgery. We've got some great videos, full metal jacket stentectomy to scare you. And we've got uniportal extended thymectomy, and we've got the best video we've probably ever done, a phenomenal interview with Vince Gaudiani and Leonard Lee telling you everything you wanted to know about mitral valve repair. So don't go away, let's listen to the whole CTSNet Beat podcast. So crisis has hit. Apparently, the CTSNet office says you guys are all on holiday in America, and thus the whole office is empty. So I've got to edit this video myself. So we're on one little tiny itty bitty camera. I've got a little candle in the corner, and we'll see if we can muddle through together with just you and me. So anyway, we've got a lot to get through this week while you eat your pumpkin pie and watch your favourite football team. Don't go away. Hopefully this little quick video can go in between the quarters, and we'll try and keep you entertained and also let you know about everything that's going on in the world of cardiothoracic surgery. And I have had a busy day because this week I went to Strasbourg and I spent quite a lot of time with the Hugo Medtronic robotics team. So I've got a lot to share with you about that, including a little tiny tipster video at the end all about going through the new Hugo robot to let you know what it's going to be like. It's going to be a banger. And the second reason I was there is actually we were leading a how to teach course. I've known a wonderful man called Professor Mark Coleman for many years, really. He is a general surgeon, he is a colorectal surgeon, and 15 years ago, when everybody was doing open hemicolectomies, he came along to teach the specialty how to do it safely. Now, he runs a wonderful course, and it's all about how to be a really good one-on-one trainer. Basically, how to be that surgeon opposite you when you're the trainee, how to get you through your CABG, how to get you through your first lobectomy. And the course starts with a question. The question is, tell me how you tied your shoelaces this morning. I'd actually like you to think for just 10 seconds, how did you tie your shoelaces? Describe it to me. Tell me how you did it. Did you have a loop in your left hand? Did you have a loop in your right hand? How did you tie them together? Now, it's not so easy. You're kind of thinking, well, how would I describe this to someone? I bet half of you reached out to your laces to try and show me how you tie them. But actually, verbally describing how you tie your shoelaces is quite difficult. And that is the difference between doing an operation and teaching an operation. And it's also called unconscious competence versus conscious competence. So a lot of you out there will be phenomenally good at a CABG, brilliant at an aortic valve and masterful at mitral valve repair. But actually, when you're banging that valve in, slipping those grafts in, you're probably looking around the room, chatting to the nurses, telling what you're going to do on the weekend. You probably have even forgotten, exactly what are the steps. And so actually, it makes it quite difficult to impart that knowledge onto your trainees. Conscious competence, however, is being able to verbally describe or take somebody else through every single step. Now, this Train the Trainer course takes you right to take apart how you train people. And it did change my life as well, because I have really changed how I become a trainer and how I do a lot of training. I do a lot of robotic training and obviously lobectomy training, etc. And it taught me a lot. It teaches you that the start of training begins not in the operating room. For me, I cheat a bit, and while you're scrubbing up, make sure you scrub up with your trainee. And in that, this is called the set. So the set, you set up what you're going to do. So describe to them, the best way is ask them what they'd like to do. What have you done previously? Let's hear your experience. What things do you find difficult? And then let's decide together what you might do in this operation. So let the trainee tell you what they think they'd like to do. You say what you'd like them to do, and set it up ready to go. Before you leave the scrub room, talk to them about the stop. Now, the stop is where, without any threatening, without any sort of aggression, the trainer says, stop. I need to tell you something about this operation, and the trainee has to put their instruments down because otherwise they don't listen to you, and you will say something about what you'd like them to do next. Now, also have a decision about the stop when you're going to take over. One of my favourite trainers while I was scrubbing used to always say, Joel, if you're a bit stuck, I might just say, let me show you how I do this. And we'll swap over, none of the nurses will know, and we'll just crack on. So we had a little code word for how to take over. So we agree our stop. Another really good tip that I took from this Train the Trainer course was have a stop every 30 minutes. It's actually a brilliant idea. Now, even in cardiac surgery, and I do it all the time in thoracic surgery, after half an hour to 45 minutes, I say, right, stop everybody, it's a timeout. Trainee, stand up, and that's really important. Get out of the surgeon console, stand up, tell the team what we've done so far and what we're going to do next. And the trainee tells everybody, well, I've taken the lymph nodes, I've taken the station 7, I've got into the fissure, next we're going to staple the PA. I actually also go around the room, check everybody's happy, the anaesthesiologist, the scrub staff. Often we'll ask for a few staplers to be prepared, get ahead with ourselves, and they'll sit down. There's a fascinating study from Harvard University Medical School that says if you have 30-minute stops for just 1 minute, you will speed up your operations, and they've actually got data to prove that you go quicker. And we have found that because you say to the scrub nurse, oh, you haven't got a stapler ready, you haven't got the glue, you haven't got the retrieval bag. So actually they get things going better. The anaesthetists respond to things. Oh, right, it's the PA. I'll just make sure I'm in here. The first assist might be there. Okay, I know what's next. I'm going to be changing some arms. And actually it has sped us up. Also, it's a great training opportunity. Oh no, I don't want you to do that next. I want you to do the following next. The other really good thing it does very well is that if you have got something you're a bit concerned about in the operation, you just go, right, everybody, time out, time to stop. And you just do it a bit early. So don't do it at 45 minutes, you do it at 20. Because actually everyone just thinks it's a stop, where actually you're wanting to do something different. So some other things of the course, they teach you about sensory overload. We actually go into a cadaveric lab with the Hugo robot, and we got people doing tasks, and then we started trying to get in their ear, trying to tell them all sorts of stuff, and it really put them off, which shows that you shouldn't be yada-yaddering as a trainer all the time. Watch, let them carry on, and stop them if it's not safe or you want to impart training. It's really good. And then at the end we do a close, so we ask the trainee what they felt they did well and things that they'd like to improve on next year, and we document it in a easy to use chart. It works great. We love it. So that is this really interesting Train the Trainer course. So we're going to have an interview with Mark Coleman just at the end of the podcast. One other little fun thing we did, we were teaching people how to do bedside stapling. But we got on the simulator, we blindfolded them, because actually normally people can do this fairly easily, but suddenly when the surgeon had to say left, right, up, down, it was like, who's left? Because, was that left? Oh, no, that's left. Rotate, left a bit. Oh, no, not left. No, I want the stapler to rotate. Do you want to articulate? So we had to get a common language, and suddenly when they were blindfolded, it was really difficult. So if you've got a difficult task, then maybe consider taking it out of your operations, do some practice with your trainees, get a common language before you go back in. It was actually really fun, and it helps training everywhere. So as a little change to our podcast formats, we're actually going to do a little topic of the week, and that was my topic of the week, how to be a better trainer. I'd actually be really interested in your thoughts on what makes a better trainer. One of my trainers for cardiac surgery was called Simon Kendall. He actually won Europe's Trainer of the Year because 64% of all heart surgery operations he did, he gave away to trainees. And he was a fascinating guy. He was really great because he kept up the tempo of the operation. Now, I felt battered half the time because he would be like, no, don't do that, stop, you're going too slowly. But actually, he always kept the tempo up. He always gave you something, and you knew when it was time to take over because he knew the time was up. And actually, he was a really good trainer. He didn't compromise on patient safety. He didn't compromise on the timing, and actually had a positive attitude. And at the end, he'd always say, "Well done." So, hopefully we can have more and more of these people in our specialty. Again, on the course, we tell trainers about the 5 levels of training. Level 1, you say nothing. Not great, because you probably should say something. Level 2, you just slag them the hell off and you say what terrible, awful surgeons they are. Again, not great. You probably know some people like that. Level 3, you say how great they are, but you don't particularly say anything about their training, and you just take over when you decide they've done enough. Again, not great. Level 4, you actually talk to them and tell them what you want, which is probably what most of us do as trainers. But level 5, you ask, what do you need to know? Often done best before the operation, but even in the operation, ask questions, don't tell. So if you're doing a bottom end, so how are you going to do this? Do you ever have any troubles with this? Or what are you going to do next? Rather than, I would like you to do the following, just say, what are you going to do next? I do get that in cardiac surgery, when the bypass clock is ticking, it needs to be quicker, but certainly in thoracics, I find it just takes 30 seconds and it works really, really well. So we will move on. We're going to put the podcast guest at the end. We've decided to put our podcast guests at the end now in our videos, just because we thought we'd have a little top topic. And this week's is training and eating turkey, of course, those 2 very important things. And before we go to our podcast guest, we're going to go through the best papers that are available on CTSNet this week. So, a really interesting paper that jumped out at us was from Barcelona in Spain, Tokyo in Japan. The first author was Nobuyuki Kajiyama and Yukiyo Abe, and it was actually a multi-center study, and it's published in JAMA Network just 2 months ago this year. And the title is Clinical Outcomes of Mitral Valve Surgery in Atrial Functional Mitral Regurgitation in the REVEAL AFMR registry. AFMR standing for Atrial Functional Mitral Regurgitation. Okay, I've got my white flag up. I'm a thoracic surgeon, but I hadn't heard of atrial functional mitral regurgitation before. So the paper says, and I will quote directly, so in addition to traditional classifications, atrial functional mitral regurg is emerging as a distinct entity characterized by the absence of mitral valve pathology, normal left ventricular function, but atrial dilatation and annular remodeling as the primary mechanism of leaflet coaptation. So basically your atrium has blown up, it's ripped the annulus apart, the leaflets don't coapt, but your ventricle's normal, your leaflet's normal, new entity. So fascinating. I thought, wow, this is interesting. Then the other really interesting things about this is first, big study. So what did they do? They took the echo reports from a huge number of centers in the group collaborative. The group collaborative was called the REVEAL registry. Wait for it. The number in this registry is 177,000 people who have had echocardiography. 8,867 had moderate or severe mitral regurg. 1,007 had atrial functional mitral regurgitation, according to the definition. And so we've got 1,000 patients to talk about. 80% of them had atrial fibrillation. Well, of course, if your atrium's dilated. And then of these, 113 have had mitral valve surgery. And of course, the rest are being followed up. So the real strengths is hugeness of the study, really good follow-up. So 1,000 days median of follow-up. And of course, the best thing was the outcomes, because the outcomes are better if you have surgery. And that's great news. So 286 patients had the primary outcome. So a composite outcome, as you might expect. But even though the patients having surgery were worse, there was a decrease in primary outcomes. So 3-year event rates were 18% if you'd had surgery and 33% if you hadn't. Obviously a composite outcome, there was death, stroke, in hospitalization, etc., etc. But it gives really good credence to normal LV, normal valve, but severe MR due to atrial dilatation. Maybe should have surgery. Great job, guys. Really nice study. Second one is a big study, so we thought we better put this in, also with a big senior author. Michael Mack is back, and he's here with James Edgerton and a load of other top co-authors. Obviously, he is at Baylor in Texas, one of our superheroes of thoracic surgery, cardiothoracic surgery, STS president, and obviously pioneer of TAVI. But this study is called Risk of Transfusion in Isolated CABG, a model developed from the STS database. So the minute you hear the STS database, you know the numbers are going to be big. And oh yes, 1,266,545 patients they got to look at. Half of those patients had blood transfusion, which I guess if you look at your own practice, about half of people do get blood, and that's blood or FFP or cryoplatelets or whatever. So they did a risk model, and the risk model was very predictive of how often you got blood. So it probably was sort of candidates that you might expect: age, body surface area, gender, because women bleed a little bit more, preoperative hematocrit, and the use of a balloon pump. But it was quite good predictively, and so they're saying that this huge study means that maybe you could use that to plan your list or plan a cell saver. Or plan resource utilization, especially in a developing world country, maybe. So good job, nice one, and worth a look if you're into planning of your blood products. Finally, next, anyway, there was a really eye-opening study in thoracics that really made me drop my coffee. I couldn't believe it. Listen to the title of this. So, the efficacy of local regional bupivacaine analgesia via an intercostal catheter, a randomized, double-blind, placebo-controlled study in lobectomy. Didier Lardinois from Basel in Switzerland and loads of co-authors did a randomized study in an extrapleural catheter or none in VATS lobectomy. Now, I've been doing VATS lobectomies for years, and I did use extrapleural cathetery for a lot of years until I found the wonderful world of cryoanalgesia. But actually, it's one of the absolute stalwart things of thoracic surgery is putting in an extrapleural catheter. I have to admit I have abandoned it because I just use cryo and some injections now. And I know a lot of other people that have abandoned it because they use liposomal bupivacaine and things like that. But actually, this was a study of putting it in versus just not putting it in and not replacing it with anything. So the study was 2 years, 2021, 2023. You got the infusion or you didn't, ropivacaine at about 6 to 8 mils an hour for 3 days after surgery. And in the control group, you just didn't get it. Got nothing. And so here's the shocking stuff. So there were 14 patients in the catheter group, 18 in the no catheter group, and as you might have guessed by the way I'm saying this is a shock horror, it didn't make any difference at all. So there was no differences in the first 24 hours in pain scores on coughing, 4.9 out of 10 in the catheter group and 4.3 in the placebo group. They were more comfortable in the placebo group. And so throughout all their outcome measures basically made no difference. So the conclusion was don't use an extrapleural catheter. Don't use the thing that's been the stalwart of minimally invasive surgery for so many years. And then it got me thinking, we've completely ditched epidurals, and yet epidurals were the stalwart of thoracotomies for decades, and yet we never use them anymore. So something that we thought was absolutely vital to our practice disappeared, and this is another thing that we used to think was absolutely vital that probably will disappear. And the good thing is they're not connected to something, one less thing in them. They can walk, they can move, they can cough, and they can go home quickly. So great job, guys. Really good analysis. I think I did say that was the last paper, but it isn't. There were 4. We always do 4 now, and this last one is a big meta-analysis. Basically, it says percutaneous transcatheter edge-to-edge repair for functional mitral regurgitation, a meta-analysis of 3 RCTs. So this is MitraClip, does it work? This is by Marcus Anker and Ulf Landmesser. It's in the Journal of American College of Cardiology, so that's a big one. These guys are from Berlin and Essen in Germany, and they basically put together the 3 biggest trials done so far: COAPT, MITRA-FR, and ReShape HF2. So just a little reminder, COAPT is a study which is comparing 614 patients, of which 302 had MitraClip and 312 had nothing. Well, best medical care, of course. Mitra FR, just the same. A MitraClip, 304 patients, 152 in the MitraClip arm and 152 in the control arm. And Reshape HF2 was 505, 250 in the MitraClip arm and 250 in the control arm. So you're getting up to basically sort of getting to 1,500 patients in 3 RCTs, randomizing to MitraClip or best medical care, and no statistically significant difference in mortality. Big inhale. So I was quite surprised by that. All my cardiologists said they live forever after a MitraClip, and it's brilliant. So clearly not. So if you actually look in, then you do get a reduced number of unplanned hospitalizations if you have a MitraClip with a hazard ratio of 0.69. So it's probably 30% less hospitalizations. And obviously, if you bundle everything together with all these rehospitalizations, you can just about squeak an outcome measure out of it, which is, yes, what they did in their trials, but no mortality benefit, a bit less in hospital, got to undergo a MitraClip. And they did change the 6-minute walk distance from baseline to 12 months. And you got an extra 32 meters of your walking. Well done. Well done, cardiologists. A beautiful 32 meters longer for all your patients in that 1,000 patient group. Well done. So I'm sure more studies need to be done. But yes, we can see that MitraClip is a very expensive intervention. It reduces your hospitalization and it makes you walk 32 meters more. Good job. Whoops. Sorry about that, that's my wife calling, but John Janeski's not here, so I can't edit it out because I have no idea how to do that. We are now, without further ado and without a break to talk to the office because it's empty, we're going to go straight on to the videos. So, undressing the full metal jacket, a case report of coronary stentectomy. This is an absolutely brilliant study, a brilliant video. It's really, really good. So Thais Fajon Vinolo and Sare Aranki did this video, and it is wonderful. It's quite quick. It's only about 10 minutes. And the really great thing is this person had like 7 stents all along the LAD. They slash the whole LAD open and they lift out, well, it's quite difficult. They tug out this massive long tube of stents with atheroma. And oh my God, these guys are brave. I was super impressed. So it looked great. And then they took a piece of radial artery, opened it up and sutured it all the way along the LAD. And then they sutured the lemur to that LAD. The patient had further grafts. And I thought that was just fantastic. They show us the post-op endarterectomy, effectively, stentectomy. And they did a great job. Lovely and still. I think it was about a 2-hour cross-clamp time, so pretty reasonable. And the lady was really, really young, in her 50s. So really good video. If you want to see CABG revascularization at its best, you know, I often think it's an undervalued specialty, and it really should be just the same level as the mitral and the aortic and the transplant surgeons. Proper revas surgery at its absolute pinnacle. This is your video. So the second video I would like to share with you is called Uniportal Robotic Assisted Extended Thymectomy. So this group, Akif Turner and Filiz Sabat, they're from Istanbul in Turkey, show us a uniportal robotic way to do a thymectomy. So they get the standard XI robot, but they put it all through one hole, just like Diego teaches us to do in our lobectomies, but they do it for a thymectomy. So one camera and 2 instruments, all a little bit crossed in there. To take this out. They show us how to take this 5 centimeter thymoma out, and they showed us their technique for how they took out the full thymus in somebody that had myasthenia gravis. Now, authors, I do a lot of thymectomy. you didn't take all the fat out. Now, one big thing from the randomized trial from the New England Journal of Medicine on on thymectomy for myasthenia gravis, it was done all open and they took all the fat out and they showed 30% less steroid use and 30% less hospital admissions. And in those days, people were super down on us not taking all the fat out. Now, you took quite a bit out, but you left quite a bit in, and you didn't use any CO2. So it was an interesting video. It's pretty good. I would have put a gel point on your CO2 port so that you could put some CO2 in. That would give you a lot more space. I would do all subxiphoid personally, and actually you could do your uniportal subxiphoid from Uniportal. You get both sides as well. But actually, it's a good video. Tell me what you think. I think it's quite interesting. And our highlight video, probably for the year. This might actually end up my end of year favourite video. This is a brilliant video of the wonderful Vince Gaudiani getting together with one of his colleague surgeons, Leonard Lee. And they got together. Leonard Lee is in New Brunswick, professor of cardiac surgery there. And Vince, of course, needs no introduction from California, Pacific Coast. And what they did is they took a particularly difficult mitral repair that Vince had done, and they discuss how he used the physiology, the anatomy to do a great repair. They stopped and started the video. They discussed how they took out all the calcium from the A1, P1 area, left a massive hole that they had to do a sliding plasty, how they did the annuloplasty ring, how they didn't do any cords to the anterior leaflets, why they didn't, how he created a whole load of cords to put in for the posterior leaflet, and they just had a great time doing it. 46 minutes, absolutely brilliant, total masterclass, and I loved it. Now, Vince, we're going to make you do this with some other people because it was so good. So maybe you'll have some suggestions for videos he's going to discuss with the authors, but we might actually get him to discuss some of the videos we get submitted with senior authors, because I think we'll learn a huge load bouncing all their amazing knowledge around the room. So well done. So that's all our Jan's pieces. That's all our videos. There is LACES coming up quite soon, December 5th to the 7th. Remember, LACES is the Latin American Cardiovascular Surgery Conference. It's actually hugely well attended by American surgeons. We're going to try and get some videos from there, but actually do go if you can. Our own Lorena Montes will be there. She's one of the organisers, and it is a great conference. So now we're getting towards the end, so I'm going to hand over to our podcast guest, which is Professor Mark Coleman, when I caught up with him in Strasbourg. And of course, don't go away, because there's always a little bit extra at the end of our podcasts. Hello, my name's Joel Dunning, and I'm absolutely delighted to be here with Professor Mark Coleman. Now, you cardiothoracic surgeons may not know Professor Mark Coleman, but he set up a whole training program 15 years ago that literally taught the whole of the UK to change from open surgery in general surgery to laparoscopic. It's an absolutely amazing training program. He now travels all over the world to teach this program, and we're actually here in Strasbourg doing a robotic version of this, but the key is how to make trainers better. So Mark, thank you so much for taking the time just to have a chat to us about it. So basically, tell us a little bit about the history of LAPCO, and then what you do differently and how you make trainers better.
Yeah, thanks Joel. So LAPCO started when it was realised through the availability of published evidence that laparoscopic colorectal surgery resulted in better outcomes, shorter hospital stay. We were fortunate enough to have NICE guidance supporting in the UK, which is a body that regulates the provision of healthcare and treatments. And as a result, NHS England, the government in effect, funded a training programme to convert colorectal surgeons from open to laparoscopic colorectal surgery. And so for about 7-8 years, we retrained about 150 colorectal consultants, which is about a quarter of the whole workforce in England, from open to laparoscopic, and we recruited 70 expert trainers to engage with training in the operating room.
So this program is actually how to teach people to come into the operating room and do one-on-one training. But what's different? What's different to just doing what we do every day with our registrars?
So we realised in training a group of consultants that our experts who were providing the training in the operating room had very different inclinations and expertises as trainers. Obviously, they were all technical experts in laparoscopic surgery, but they were like herding cats to try and get them to train in an elevated and standardised way to maximise safety and to shorten the learning curve for laparoscopic colorectal surgery, which is quite long.
Yep. So maybe give us a little flavour. So today we've been telling trainers about how to do a set, how to engage first of all before you even go to the OR and set the parameters for the training, set parameters for when to stop, then going into the operating room and then giving feedback. So give us a little flavour of how you pass that on to your trainers.
Yeah, so the course firstly is bespoke around the technique of laparoscopic colorectal surgery or robotic surgery and can be reprovisioned in any surgical specialty, but it is bespoke around the technique and it's interactive. The delegates are obviously surgeons, but also the faculty are practicing surgeons as well. And we start by examining everybody's prior experience as trainers and in surgical education. And then we start talking about concepts like conscious competence, how to avoid taking over in theatre, what is dual task interference or cognitive overload, how to give the best forms of instruction whilst training in the operating room, how to deliver feedback, how to assess training, how to deal, dare we say it, with difficult colleagues. And then more recently we've embedded concepts like human factors, team training, incivility and its negative effects on functions of teams. So we've created a course that involves a lot of dialogue between the delegates, but also a lot of role play as well. Some of our courses involve skills lab based role play, but also we have a course where we go into the operating room on day 2 and we get our delegates to do training either with robotic or laparoscopic surgery in the operating room live, and we also conduct validated assessments on the delegates to make sure that the trainers concepts that we're helping them to realise are being embedded.
And what difference do you feel this makes to the trainers? So there might be some cardiothoracic surgeons out there saying, well, this sounds interesting, I find training quite difficult. You know, what benefits have you heard for trainers?
Yeah, well, we were faced with the same challenges when we started this course. Was it a course that had a genuine impact? So what we did was we did the usual sort of what we call level 1 testing with course evaluation questionnaires, and then we did some pre and post course testing of the delegates' inclinations and abilities to train using a structured form. And then that was what we call learning, if you like, from the course. We also tested transfer, so-called level 3, where we looked at the inclinations abilities of those delegate trainers before and after they went on the course with their own trainees, their own residents and their own fellows. And then finally, and most compellingly, we looked at the learning curves of laparoscopic colorectal surgery for those delegate trainers before and after they went on the course, and we published that. So it's probably the most rigorously assessed surgical course ever, and it's published in Annals of Surgery.
Oh, that's absolutely amazing. And so I guess we were discussing that, you know, this hasn't really impacted in cardiothoracic surgery. It's done in very small groups, you know, just literally sometimes 6 delegates really. As you say, you have a day talking about how to train better. You actually really go and do it, which is very unique. I love that idea that you could actually go and the next day train it. So maybe just in a few words, you know, how could it benefit training in cardiothoracic surgery worldwide, really?
Yeah, I mean, we have an evidence base that shows that the course is positive in its impact at all levels. It would be very easy to redesign the course for the needs of cardiothoracic surgeons who do particularly minimal access VATS type surgery, robotic surgery, but also conventional open surgery as well, and give the surgeons that do train a number of extra tools, hopefully, in their toolbox as trainers that they can use day to day in their lives as surgical trainers.
And also on the website, you do have some forms for post-op evaluations and things. So tell us a bit about that.
Yeah, so we also are in the business of generating digital portfolios. Many countries, many surgeons don't have digital portfolios that allow trainees to map out their progress as trainers. So we have digital formative assessment tools, summative assessment tools, and tools that give structured feedback to trainers as well about their abilities in that area.
Yeah, fantastic. And actually there's a little website, here it is up behind us, and what can people find on the website really? I guess a lot of information about what...
Yeah, I mean, that's a good question. Our dream is to roll out digital portfolios and train the trainers globally. The courses are traditionally face-to-face, but we've certainly got experience of doing digital interaction online as well. We also help to generate faculty, and they may be of interest to cardiothoracic surgeons in various parts of the world that are interested in forming their own train-the-trainers course within your own specialty. And we also want to, as I say, create digital portfolios for trainees globally where they are able to store all of their progress through training, including course attendance, certifications, exams, in a single sign-on secure domain that can allow them to make good progress with their training and record at the same time.
Yeah, I mean, and certainly to finish up, really, in my own practice, having helped out with this course a little bit, I think I totally changed the way I did training. I think at the start, while I was maybe scrubbing with my registrar, I would talk about, right, what are we going to do? What's your aims and aspirations? This is how we're going to do it. And we talk a little about when we're going to stop. I actually instituted a 30-minute stop, which you do quite a lot, because it's very difficult to talk to someone while they're in the middle of their training. So we stop, get them out the console on robotics, and they'll talk to the whole team. Something I love here is we've just been doing teaching interactions between surgeons and the bedside assistants, which is new, isn't it? And that's really helped. And then going back and having a talk afterwards, generally when I'm closing up the holes, I'll say to the trainee, right, how did you do? How did that go? So it certainly impacted my practice a lot. So
absolutely,
I think it does help.
And, no areas focus the mind on training more than, say, robotic surgery, where there's that sort of geographical separation between the bedside team and the console surgeon. There's often noisy interference. And understanding and setting the scene for training to be safe and effective is really important. And we, through testimonials published on our website, it's obvious there that surgeons really appreciate this course, and it has an impactful effect on the way that they train.
And mate, just an absolute final question. A lot of people are like, well, we'll just let the robot companies do it. So, should they just do all our training? Why do you need a course?
I think this course particularly fills the gap between the end of the technical skills training, which the companies do extremely well, and the process of guaranteeing and verifying that a surgeon is safe and competent to perform major laparoscopic or robotic procedures independently and safely. So I think that's where it comes in, and particularly to help robotic proctors become better trainers as well, and to understand the importance of their role as trainers.
Yeah, great. Well, absolutely fantastic. It's been a great course. We're just finishing up here in Strasbourg, and thank you so much for coming to talk to us. It's absolutely brilliant. Thanks a lot.
Thank you, Joel. Appreciate it.
Well, thank you, Mark, for that wonderful interview. And of course, if you're interested in the Train the Trainer courses and LAPCO, then do get in contact with him on that website, lapcointernational.co.uk. So we're at the end of the podcast. And of course, we open up to the very special part of this podcast, because this is just for you. This is just for my VIPs. Yes, if you would like to be a podcast VIP, the only qualification is listening all the way to the end, because I only want to talk to people on WhatsApp, to my good friends who are listening all the way to the end. If you would like to be on it, send me a WhatsApp message to +44 780 154 8122, and I will add you to a guest. And we have had some new guests this week, so welcome Ewan. Ewan is an upper GI surgeon. He is a surgeon in Birmingham in the United Kingdom. He really enjoys listening to this podcast, even though this wacky cardiac and thoracic surgeon mystifies him a bit. He's really pleased when we do some proper surgery on the esophagus. But he's really interested, and it's great to have an upper GI surgeon. Now, you Americans are going, what? You Brits, you don't do much esophageal? Yeah, we don't. We have specialist GI surgeons doing our esophagectomy surgery. So it's great to have you on the loop, Ewan, and I hope to keep in contact with you on the VIP Club. Just like I'm keeping in contact with Mahmoud al-Baghdadi. You're from Egypt and you're a cardiac surgery specialist at the Aenas Hospital. They do adult and congenital surgery, and they do all sorts of surgeries apart from transplants and VADs. But Egypt is a great place to do surgery. We've got so many people there really, really interested. Mahmoud really likes congenital cardiac surgery, and he gives us a big thumbs up for the VIP Club. So great to have you as part of the club. And Vincent Sear. So Vincent, thank you very much for joining the VIP Club. He is a PhD student from Leiden in the Netherlands, and he wants to be a full cardiovascular surgeon, and he's in training. He's been researching, listen to this, the personality of cardiothoracic surgeons. Vincent, I'm having you on the podcast. I want to know what you found out. I'm really interested. So I might get you on the podcast. We're actually trying to get our student who used to work for SpaceX to do a podcast. If you're listening, I'm chasing you, and I'm definitely going to get Vincent on the podcast when he's done his research in the personality of us cranks. So that's it for the podcast. Apart from a little further tidbit for you VIPs, I recorded just a quick 2-minute video just looking around the Hugo robot this week. So I will finish by giving you a tour of the future of robotic surgery.
Well, hello. I'm here at ECAD Strasbourg, and here we are with the Hugo robot. We've been having a really good few days with it. We've been trying out how it works for thoracic surgery, which has been very exciting, in cadavers and pigs, and we're doing some dry lab stuff today. But yeah, let's take a look. So it's a lovely big open screen. It's actually got two kind of Nintendo Wii things, so if it detects your glasses looking away, it locks the instruments. Lovely pistol grips, which are really, really very helpful. We've got our full range of foot pedals down there. It's all ready for ligashore and ligashore cut, ligashore seal, which will be coming very soon. Bipolar, monopolar. Something I really like is a separate screen for all your settings. You've got a really good fine, normal, and rotation's really good. You can rotate much faster, twice as quick to do suturing, which is a really, really great advantage. You've of course got a great vision carts with a nice screen. Doesn't tell us straight, but that will come soon, I'm sure. And then here we go. Here are the arms. These arms look really nice. They're quite easy to move around. You can get instruments out pretty easily. So out they come, and who knows if I've just broken it. And you can set it up 3 ports, 4 ports, all sorts of things. Very nicely. They've got a full range of instruments. They've got anything you like. So you've got Maryland, bipolars, sutures, and graspers. And so very nice. Let's have a look at how big it is. Fits around a patient pretty well, I think. These towers are about the size, about 5 foot, and quite mobile. And they've got really good reach, so you can actually reach right over. So there haven't been much problems with clashing or anything like that. So that is the Hugo Medtronic robot. Really quite awesome. I hear there have been 10,000 cases done worldwide in 60 countries. So it's 23 countries, 60 systems, and it's just going to get better and better. So I hope you enjoyed our little whiz around, and I'm sure we're going to hear a lot more about Hugo, particularly in thoracic surgery, probably at the start of next year.